Kia ora. Well, the next few slides give an overview of malignant hyperthermia during cardiopulmonary bypass and deal with the identification and recognition of the signs of malignant hyperthermia and some remedies that can be put into place if we encounter this either before or during cardiopulmonary bypass. I've avoided discussing malignant hyperthermia in respect of anesthesia and focus primarily from the perfusionist's point of view. So the current thinking in the pathophysiology of malignant hyperthermia is the susceptibility arises from the underlying abnormalities in the ryanodine 1 receptor on chromosome 19 and a couple of other receptors, the calcium voltage-gated channel subnet alpha 1, subnet alpha S on chromosome 1, and on chromosome 12, the SH3 and cysteine-rich domain 3 protein. And so these genes are affected. And ryanodine receptors sit on the sarcoplasmic reticulum of the myocytes, and they're essential to the excitation-contraction coupling. So what happens is an action potential is generated in the myocyte, and it travels down T-tubules to the sarcoplasmic reticulum, where calcium is released by coupling of the ryanodine receptor with dihydropyridine receptors in skeletal muscle, or by calcium-induced calcium release in the cardiac myocytes. This leads to an increased intracellular calcium overload, and so you get dysregulation of muscle contraction. This leads to rigidity, and as a result you have hypercarbia and hyperthermia. In essence, you have a hypermetabolic state. So the incidence of malignant hyperthermia is really pretty rare. For patients having general anesthesia, as we can see, 1 in 15,000 in children and 1 in 50 to 100,000. Sometimes some papers quote 1 in 200,000 adults having a general anesthesia, and it probably is underreported. So from 1982 to 2016, in the review paper that I've used for this presentation, only 30 cases reported in cardiopulmonary bypass patients. And if you look at the literature, there are probably half a dozen or more case reports in the literature since 2016 to date. And of those patients, only a small number became apparent during the course of cardiopulmonary bypass. So most of these cases are known prior to surgery, and therefore something can be done about it. So the indications for malignant hyperthermia are shown on this slide, and in essence, either you have signs of hypermetabolism, or you have muscle rigidity and hypercontractility, probably both, more likely the former. And we can see how this exhibits tachycardia, hypocarbia, acidosis. Ultimately, you get hyperthermia. And in terms of cardiopulmonary bypass, hyperthermia has not been noted in these case reports during the case, because you have control over the temperature, and it's only after you come off that you get this hyperthermia. If you have patients where malignant hyperthermia only becomes apparent during the case, it is going to behave pretty much like an oxygenator failure. And what you're going to see is extreme hypercarbia. You're going to see SVO2s plummeting and probably difficulty in oxygenation. And your immediate thought probably would be to go to gas supply and possible oxygenator failure. You also need to look at the urine. You can see myoglobin and your lab results are probably going to show elevated potassium. So, having been confronted with this problem, what are you going to do about it? Well, the first thing to do is to remove the triggers for malignant hyperthermia, which are depolarizing muscle relaxants, seldom used, I have to say, and volatile anesthetic agents. So as far as we're concerned, isoflurane. And so if we have a patient where we have suspected MH, and most of the patients fall into this category, we can do this prophylactically, if you will, prior to going into the operating room. And we have now set up a little box with replacement tubing, and so we're going to take the vaporizer off, replace the silastic tubing from the electronic blender through to the oxygenator, in essence. And if time permits, you take an unprimed pump and reset that up. And if it doesn't, and you're in a bit of a hurry, or you want to use the prime pump, you probably want to ventilate it for a while, which is similar to the recommendations for the anesthetic circuit. We've got ventilated for 10 minutes at 10 litres per minute. It's probably unlikely that there is any residual isoflurane left in the prime after the CO2 flush. So the somewhat more challenging situation is if a patient exhibits malignant hyperthermia during the bypass run, previously unsuspected. And in this case, what you're going to see is this increasing hypercarbia, desaturation of venous blood, probably a drop in PO2, the sorts of things that you would expect to see if you had disconnection of gas tubing, or if your muscle relaxant had worn off. And in fact, it's a similar situation where you've got a hypermetabolic state occurring. And so malignant hyperthermia has to be included in your differential diagnosis of this kind of problem. And having ascertained that it's malignant hyperthermia as opposed to any of the other things that might cause this, the steps are set out here in this guide from the literature, which are fairly straightforward. Clearly, you're going to notify the surgeon. You're going to remove the isotech, the vaporizer, and then deal with the hyperkalemia. You may have to deal with increasing potassiums, and so Z buffers with 0% potassium replacement solution is a possibility. And temperature shouldn't be an issue. You should be able to have control over that. Now, having removed the triggers, then you should be able to retain control of your acid-base status. If you're not on bypass, or you come off bypass, and this is not infrequent in the case reports where these situations exhibit themselves, hypercarbia, and then you get this increasing patient temperature, you can consider going back onto bypass to again get control of the situation while IV dantrolene is given. And dantrolene is the solution, if you will, for this. Prior to dantrolene being identified as an inhibitor of these pathways, the mortality was 80%, and now it's probably down to about 5%. So this case report is just one example of malignant hyperthermia that has become evident during the cardiopulmonary bypass run. And you can see it's from 2019. What they saw, and you can see on the table, is a marked, this has occurred as they were coming off bypass. So the bypass run itself didn't exhibit any of these signs, but as they were weaning, suddenly you can see the venous saturation plummeting to as low as 29%, and a marked increase in PCO2, up to, and this is in millimeters of mercury, 74, big drop in PO2s barely registering, and a huge increase in lactate. And so what they did was eventually to go back on to bypass and try and correct and get control of all of this. The lactate remained very high even throughout. And this case report, amongst others, is now on the L drive. Out of interest, I've included this clinical grading scale from Larach and colleagues from Anesthesiology 1994. And while it is quite an old paper, it is still cited in the most recent reviews and case reports of patients with malignant hyperthermia as a tool to predict their susceptibility. And you can see there's a grading scale on the left-hand side, and then if you score a certain number of points, it shows the likelihood that the patient has malignant hyperthermia. And again, this paper is on the L drive.